Well, hello there, and welcome to this lecture on medications that are used to treat Parkinson's. So this is the Antiparkinson Drugs lecture. So Parkinson's is a neurodegenerative disorder that affects the nervous system, primarily impacting movement. It's basically caused by a gradual loss of dopamine-producing neurons in a part of the brain that's called the substantia nigra. Now, dopamine is a neurotransmitter that plays a key role in regulating movement and coordination. And when we have an imbalance between dopamine and acetylcholine, because normally these two neurotransmitters work together, but with the loss of the dopamine-producing neurons, there's an increase in the acetylcholine activity. So this imbalance contributes to the motor symptoms of Parkinson's that we'll talk about in just a moment. But what we do know is that we can partially control the symptoms, though not the progression of the disease, as long as there are still some functioning nerve terminals available to take up that dopamine. So the classic symptoms of Parkinson's include things like tremor, which is that shaking, which often starts in the hands and the arms. Bradykinesia, which is a slowness of movement and difficulty initiating movements. Rigidity, which is stiff muscles that can limit range of motion. Postural instability, which is problems with balance and coordination, which leads to falls. That shuffling gait, that's as a result of the dyskinesia. And drooling. Of note here's a picture of one of my favorite actors, Michael J. Fox, who had early onset Parkinson's disease, and he still continues his fight today. All right, so with Parkinson's, there's also a lot of non-motor symptoms that the patient experiences, often depression and anxiety, sleep issues, cognitive changes, constipation. And although the exact cause of Parkinson's really isn't known, we do believe it to result from a combination of genetic and environmental factors. And since there's no cure for it, there are several treatment options, which medications, especially the dopaminergic medications like levodopa, are commonly used to increase dopamine levels in the brain. However, with Parkinson's disease, they tend to have this on-off phenomenon that's in response to the levodopa. So basically their disease will worsen when there's too little dopamine present. And then dyskinesia, which is the difficulty performing voluntary movements, occurs when there's too much dopamine present as well. And then the wearing off phenomenon, which we'll get to a little bit, which is basically that the medications aren't working the way they should and they don't last as long. And then there's something called Parkinson's disease-associated dementia, or Lewy body dementia. So Lewy body dementia is a type of progressive dementia caused by abnormal deposits of this protein in the brain, which are known as Lewy bodies. And those deposits affect chemicals in the brain that are crucial for thinking, movement, and behavior. Something to note is that Robin Williams was initially diagnosed with Parkinson's disease because of his symptoms that he was having, but after his death, it was revealed that he actually had Lewy body dementia. And again, the range of symptoms with his cognitive decline, visual hallucinations, movement disorders. And his widow had said that he had been suffering from anxiety and depression as well. A reminder of dyskinesia, which is basically difficulty with performing voluntary movements. Now, a patient with Parkinson's disease can definitely have dyskinesia as a sign of their disease, but there's also a levodopa-induced dyskinesia, which is a side effect of long-term levodopa therapy. So that manifests as involuntary, erratic, and excessive movements. And these movements often occur when the medication's at its peak, typically a few hours after taking the dose. All right, so let's look at the treatment of Parkinson's disease. So this really does require an interdisciplinary approach. The patient with Parkinson's disease is going to need medical care, physical therapy care, occupational therapy, speech-language pathology, the whole works. Medications are really only one part of the treatment. And as a reminder that the medications don't slow the progression of the disease, they just help with the symptom management. So the medications that we are giving are to work on that imbalance of dopamine versus acetylcholine. So we either want to increase the amount of dopamine that's available in the brain or decrease the action of acetylcholine so that we have a better match in the brain. And there are a couple of new meds that are being used for our so-called off episodes. So I just listed them here, and we'll talk about them when it's appropriate to. So many times we hear that medications are contraindicated if a patient's on an MAOI, and we usually consider those to be kind of older meds that aren't used as much anymore. And to some extent that's true. However, we still will use them in the case of Parkinson's disease, especially the selective MAOI, so MAOB inhibitors. Now, these are a class of medications that are used to treat Parkinson's disease. So you see over here selegiline and rasalgiline. So these are not the same as the non-selective. So basically, these work by blocking the enzyme monoamine oxidase B, which breaks down dopamine. So by inhibiting that enzyme, the inhibitors help increase the availability of dopamine, which can improve the motor symptoms of Parkinson's. So the couple that we'll look at here are rasalgiline and selegiline. All right, so selegiline is often used as an early monotherapy or in combination with levodopa, and rasalgiline can be used alone or with other Parkinson's medications. Basically, the benefit to these medications is that they can help reduce tremors and stiffness and bradykinesia, and they can extend the effect of levodopa, so they can kind of prolong the effect and decrease those off periods when the medication is not working. Some of the side effects would be headache. That's a very common side effect. Nausea, insomnia, and hallucinations are rare but possible. So one of the problems with MAOIs is their ability to elicit the cheese effect, right? So the cheese effect is called that because the interactions with the tyramine-containing foods like cheese, red wine, beer, and yogurt that can cause severe hypertension. So for these classes of medications here, like selegiline, if we're using a dose of 10 milligrams or less, then it will not exhibit the cheese effect. There is an interaction between selegiline and rasalgiline and meperidine. So if we use those medications together, it will increase the risk of respiratory depression, low blood pressure, and potentially cause serotonin syndrome. Now, one thing to know is that meperidine, which is also known as Demerol, is not commonly used. While we're on, this slide, I think we should just mention serotonin syndrome. Basically, the signs and symptoms of serotonin syndrome would include things like confusion, hallucinations, seizures, extreme changes in blood pressure, increased heart rate, fever, sweating, shivering, blurred vision, tremors and spasms, nausea, vomiting, and diarrhea. All right, let's move on to the next med. We learned about amantadine under our respiratory section under antivirals. So amantadine at one point was used to treat influenza, not so much anymore, but it definitely is used to help in Parkinson's because it basically increases the release of dopamine from the nerve endings in the brain and enhances the response to norepinephrine. So this helps sort of alleviate the motor symptoms associated with Parkinson's disease, such as tremors and muscle rigidity. And then it also inhibits one of the glutamate receptors, so that helps reduce dyskinesia that can occur as a side effect of long-term levodopa therapy. So basically, our patient will have, hopefully, improved motor function and reduce the severity of Parkinson's disease. It's often used as an add-on to levodopa and to manage those fluctuations of motor activity and dyskinesia. Often used early in the disease because it's only effective for 6 to 12 months. So COMT inhibitors, or catechol orthomethyltransferase inhibitors, it's a mouthful, isn't it? They basically prolong the duration and action of levodopa that results in the reduced wearing off effect. These medications, including the one that I have here as the most common, is entacapone or Comtan. They can darken a patient's urine and their sweat. This wearing off phenomenon, that actually occurs when these anti-Parkinson medications begin to lose their effectiveness despite maximal dosage as the disease progresses. There are some contraindications and things like that. So contraindicated in patients who have, of course, hypersensitivity or have pre-existing liver disease. That's because these things can be hepatotoxic, so we want to know where our patient is initially, and we don't want to make any liver failure worse. Direct-acting dopamine receptor agonists are medications that mimic the action of dopamine in the brain. They basically bind to dopamine receptors and activate them, helping to alleviate the symptoms of Parkinson's disease by compensating for the low levels of dopamine. So they're kind of doing the dopamine's job. Now there's two classes, which are the non-dopamine receptor agonists, and then of course dopamine replacement drugs. So let's look at some of these. So bromocriptine is a dopamine receptor agonist that belongs to the class of medications called the ergoalkaloids, and it's used to treat several conditions, including Parkinson's disease, to help manage the symptoms by stimulating dopamine receptors. It treats hyperprolactinemia, so it reduces the high levels of prolactin. It's also often used for treatment of acromegaly. So remember, that's that condition caused by excessive growth hormone, usually due to pituitary tumors. And it actually can be used to help control blood sugars as well. So some of the common side effects include nausea, dizziness, headache, orthostatic hypotension. It can also cause some serious side effects like heart valve issues and psychiatric syndromes. When treating patients with Parkinson's disease, this allows a lower dose of levodopa to be used. Now, bromocriptine, we want to use it cautiously in patients with peripheral vascular disease because it can cause vasospasms, and those are sudden constrictions of the blood vessels. And in severe cases, these vasospasms can result in a heart attack or stroke. Bromocriptine taken along with erythromycin can lead to higher levels of bromocriptine in the blood, and that can cause excessive dopamine receptor stimulation. And if you take these, the interaction between bromocriptine and adrenergic drugs is that using them together can potentially cause high blood pressure and tachycardia. Pramipexole is very similar to ropinirole and rotagodine. Usually you're using either pramipexole or ropinirole, or Requip. Basically, it stimulates the dopamine receptors in the brain to improve motor function. And also, in addition to being used for Parkinson's disease, it's also used to treat restless leg syndrome. So some of the common side effects would include nausea, dizziness, drowsiness, sudden sleep onset. Also some problems with potentially impulse control issues like gambling and excessive eating. But the good part for our patients with Parkinson's is that it may delay the need for levodopa, and it can be used as single-line therapy or as adjunctive or additional therapy. So now let's get into some of the replacements. So levodopa, often called L-dopa, is a precursor to dopamine. Now, levodopa was first isolated from the seeds of the broad bean by an Italian chemist in around 1910, so over 100 years ago. And then a Swiss biochemist, actually isolated the chemical structure a couple of years later. But the true potential of levodopa in treating Parkinson's wasn't discovered until much later, in 1961, when these researchers demonstrated that it had a miraculous effect on patients with Parkinson's disease, which led to its widespread use and treatment. So levodopa, we don't give that by itself. We give it with a medication called carbidopa, and we'll talk about that why in just a minute. But in general, carbidopa inhibits the breakdown of levodopa in the peripheral area, which allows smaller doses of levodopa to be used. Because if a person takes large amounts of levodopa, there are side effects. So things to think about with L-Dopa is that it becomes difficult to control the disease even with levodopa after several years. And the medication stops working, and as a result, the medication will lose its efficacy. So levodopa crosses the blood-brain barrier, but carbidopa does not. So we use them together, levodopa and carbidopa, because carbidopa prevents the levodopa from being broken down and allows more of it to cross the blood-brain barrier where it can actually be converted to dopamine. So let's look at some of the contraindications to the therapy and some of the common adverse effects. All right, so carbidopa, levodopa, or from here on out, I'm just going to call it Sinemet because that is the brand name of it. So Sinemet's just easier to say. So Sinemet's contraindicated in cases of angle closure glaucoma and used very cautiously in folks with open angle glaucoma. And the reason for this is that Sinemet can increase intraocular pressure. Some common adverse reactions include palpitations from heart dysrhythmias, low blood pressure, urinary retention, dyskinesia, depression. Also, something I don't have written on here, but I think was kind of neat, is that you don't want to use Sinemet in patients with a history of malignant melanoma because the medication can activate melanoma cells. And you don't want to use MAOI inhibitors at the same time as Sinemet. Another use of carbidopa is to treat the nausea that's associated with the Sinemet treatment. If we have the controlled release, it tends to work for a longer period of time. And of course, there's drug interactions with tricyclic antidepressants. So for our teaching, the Sinemet is best taken on an empty stomach because there's those GI side effects. And if there are, you can take it with food. But again, an empty stomach would be preferred. Anticholinergic therapy. So remember, anticholinergics block the effect of acetylcholine, and these are used to help treat the muscle tremors and the rigidity, but they do not relieve the bradykinesia. Anticholinergics are basically known as those medications which cause increased dryness throughout the body. So benzotropine or cogentin is the anticholinergic drug of choice for Parkinson's disease, and it's for those who also may suffer from the extrapyramidal effects of antipsychotic medications. Some of the problems associated with this would be dry mouth, so reduced spit production, dry eyes, dry everything, right? Can't see, can't pee, can't spit, and you can't poop. All right, so be very cautious during hot weather because of the increased risk of hyperthermia. There could be an anticholinergic syndrome that occurs because of this. Dry mouth can be managed with artificial saliva, lemon drops, gum, frequent mouth care, fluids, sucking on sugar-free candy. Anticholinergics should be taken with or after meals to minimize their gastrointestinal discomfort, and we don't want to discontinue these suddenly. As far as fluid intake, we do recommend that patients drink at least 3 liters a day if it's not contraindicated. And that's even if they're not thirsty because of the adverse effects of constipation and potential dehydration. All right, so I have this little slide here for you, which I like. This is all about anticholinergics and what they can cause. And so you can definitely pause on here and take a peek at that. Patients diagnosed with Parkinson's disease and are studying on anti-Parkinson medication. Nursing implications are to definitely perform a thorough assessment, look at their meds, look at their history, looking for signs and symptoms of Parkinson's disease to see where their baseline is. Make sure you talk to the patient about their central nervous system findings, their stomach issues, GU issues, like if they already have pre-existing issues. And make sure we're paying attention to the psychological and emotional status of our patients with Parkinson's disease. Patients should be taught not to take any other medications unless they've spoken to their provider. When starting any of these dopaminergic drugs, dizziness can occur and the patient may need extra help to avoid falls. Remember that we can give the oral doses with food if they have GI problems with them, are 3 liters of fluid a day. If you take levodopa with MAOIs, the patient may develop a hypertensive crisis. The medication should not be discontinued abruptly. We want to tell our patient what the therapeutic expectation is for them because it's not going to relieve all of their symptoms. Please understand that. And that we have that wearing off syndrome that's going to potentially occur. Therapeutically, the effects of those COMT inhibitors may be in a few days, but other drugs, few weeks. Make sure we're monitoring therapeutic response to the medications. The patient should definitely be feeling better, have a better sense of well-being. Mental status should be stable and improving. They should be able to eat appropriately, increased ability to perform those activities of daily living, increased focus and mind clarity, and less intense, but probably not gone, manifestations of Parkinson's. All right, guys, so thanks for sticking with me through this lecture. Here's your obligatory cartoon. This is from Cyanide and Happiness. It says, the results came in. The doctor says I have Parkinson's disease. Yikes, how are you holding up? Because I'm pretty shaken about it. I think we'll end there. All right, guys, Parkinson's disease is a life-altering diagnosis for your patients to get, so be kind, be accurate with the information you give them, and most of all, be a great clinician and a great nurse. Thank you.